Welcome. Today we have the privilege of meeting with Dr. Eric Peterson, one of our lead physician leaders and practicing emergency medicine physician for our American Physician Partners team, about the opiate epidemic. Eric, can you tell us a little bit more about how this opiate epidemic and this prescription drug crisis is affecting our patients in the emergency department?
Tony, that's such a great question. We see it every day in the emergency department, and it is a crisis. The number of prescriptions written today is nearly 4 times what it was when I first started practice 20 years ago. In fact, the leading cause of accidental death in the United States right now is prescription drug overdose. 20,000 of the 50,000 deaths are related to opiate prescriptions. 12,000 of those deaths are related to heroin use. In fact, in 2015, 259 million opiate prescriptions were written in the United States, which would supply enough hydrocodone for every adult to take a dose every 4 hours for a month.
Wow. You know, just 2 weeks ago, the president and our national leaders declared an opiate crisis, a state of emergency in healthcare to really try and tackle this issue. I saw a statistic yesterday that said 91 deaths occur a day due to an opiate overdose. There's 2 million Americans addicted to prescription pain medications. What do you think we could do as a company to help address this?
Well, I think we're right now doing leading edge medicine around how to temper this opiate crisis. In fact, we've done a CPI activity which really is based on responsible opiate prescribing. We attest every physician that they're enrolled in their state's prescription drug monitoring program. We provide 2 very robust CME activities about responsible opiate prescribing. We encourage each site medical director to work with their nursing director to create not only a policy for responsible prescribing, but also for referral to those patients that need referral to a chronic pain management or even an addiction facility. And that's no small task, because that's a part of medicine that's really underserved.
So as a company, as we've tackled this with a goal of trying to practice safer medicine and provide a safer alternative in our communities through education and consistency in our clinical practice within our emergency departments, I think our opiate management program is really cutting edge, best practice clinical care that we're bringing to the field of emergency medicine. In your clinical practice, how have you seen this play out in the emergency departments where you're leading?
Well, I think it's really been phased in over time. We've been so caught up when patient satisfaction, all the providers thought, well, geez, if I'm not giving the opiate pain medication for every ache and pain, is this going to affect patient satisfaction? We've really gotten over that hurdle, and I think that was the first major step. Now providers are really jumping on board with responsible prescribing. They don't prescribe much. If they do prescribe more than 3 days worth of pills, then they're documenting in the EMR that they've consulted their state's prescription drug monitoring program, and they've made sure that there's no contract with a pain clinic. On the other side of this, I also think that we see far fewer patients in the emergency department that are there with chronic pain. So it's getting out into the community that the emergency department is not the place to receive opiate pain medication.
Eric, talk a little bit. Sometimes as physician leaders, we're challenged with how do we help coach and mentor our team to having these difficult conversations. And sometimes we see the negative outcomes that come from a just say no mentality or a confrontational no at the bedside, and what that escalates into and creates disruption in the emergency department. What strategies have you used to help coach and mentor physicians that you're leading on how to say no appropriately, and then how to put some context around our desire to practice safe medicine around the opiate prescription crisis?
That is a great question, and it's certainly a challenge that comes with gray hairs and years of experience. I think what I found, Tony, is this. It's very simple. Nothing changes throughout the entire realm of medicine, whether it's a heart attack, stroke, or someone that's suffering from opioid dependence. You have to sit down at the bedside, explain what the issues are. What they're doing is not healthy for them. By and large, if you have an open conversation, if you're honest and engaging with them and the family that they have there, they'll open up to you and they'll admit that they may have a problem. If you talk like you're understanding and compassionate to what they're going through, they'll tell you what has caused this problem. And I think as emergency physicians, we get so caught up in the speed that we need to take care of patients. This is a special population of patient that we need to spend a little extra time with, and we can really get to the bottom of their issues and get them the help that they need.
And we talk often in our company and working with our teams as we're coaching them about closing the visit. And this is one of those critical encounters where it's important, as you said, to sit down at the bedside, to connect with our patients and to share with them that we're wanting to help them in the situation that they're finding or the addiction that they find themselves in. As I think back about it, it's not always the patient's fault that they find themselves in this situation. Thinking back to those statistics about how many pain prescriptions we used to prescribe from the emergency department, how many pain prescriptions would come from all aspects or fields of medicine with a desire to alleviate pain and provide a comfort for our patients. And realizing only now in the last 4 or 5 years the severity or the damage created by that overprescribing of opiate pain medication. And so I think part of this is taking an acknowledgement at the bedside to say, with our patients, we understand the dilemma or situation you find yourself in. It's not your fault, but we want to offer some help. In sharing with that next step, what other adjuncts should we pull in? Does case management have a role? And what outpatient therapy or resources would you recommend that could help patients once they leave the emergency department recover from their addiction?
So as a company with American Physician Partners, as a regional director, my job really is to mentor the medical directors and what's appropriate to create inside of the department. First, they have to understand that this crisis exists. I think everyone understands that. What they don't understand is where to go, what resources are out there to help these patients. You have to sit down with your nursing leadership in the department and create a community list of what's available to help them if they need it, whether that's pain management or whether that's addiction services. That needs to be a very robust list where you can present this back to the patient to say, here are some of the best resources we have available in the community. This one takes insurance, this one is cash. We have to know everything about those. Case management, I think, does have a role, and they can help communicate what it's going to take for that patient and their family to get enrolled in a pain management center or an addiction facility. I think it's also the responsibility of our local leadership to get out into the community and understand where those facilities are, who the doctors are, so we can even more effectively communicate with the patients what they're up against and how we can help them.
Any strategies that we could share with our emergency medicine team about key elements to touch on at the discharge or time of discharge with a patient who we're sending home, knowing that we've limited the pain prescription for them, but things that we could share with them or keyword or key interventions or advice that we could give them that would help them have a more successful post-ED visit experience?
So I think as providers, we need to understand what happens in 3 days if they run out of their opiates. They're going to get sick, they're going to start sweating, they're going to feel terrible. We have to set the expectation for the patient so they understand what they're up against. It's maybe not enough for us just to prescribe 3 days of medication. What happens then if they can't get in to one of these facilities that we've talked about? What other modalities can we use? Can we give them nausea medicine? Can we give them some other things that may help alleviate some of their withdrawal symptoms? Let them know that we understand that that's happening and we want to do our best to help them fight through that. That gives them a sense of trust to us, that we understand what they're going through, and they're more likely to fight through it and seek the help that they need.
What is the role of Suboxone in the opiate crisis?
So that's another fantastic question, and I think it's a modality that is drastically underutilized. I personally have some experience in an addiction clinic where I help these patients, and the reason I got involved with that, Tony, was as a practicing emergency physician, what we just talked about, we need resources, where to refer patients and addiction type clinics. And when we started doing that at one big center that I was the medical director in, there were no places to send them. So we created this place and would prescribe Suboxone, and if used responsibly in conjunction with therapy, group sessions, and all the appropriate treatment that we can provide opioid addicts, it works very well. It eliminates their withdrawal. It eliminates their craving for more. We can stabilize the dose and then over time decrease that dose to the point where they're off of opiates. They'll always have substance use disorder or addiction, but this gets them on the road to treatment without trying to find drugs off the street, turning to heroin, or frequently visiting emergency departments.
As I look at the direction we're moving in emergency medicine and our goal to really practice high quality, evidence-based, best practice medicine to deliver a high quality, compassionate care experience to each patient we serve, our approach and our forward thinking and aggressive implementation of our opiate management program has really been a success this year. Thank you, Eric, for sharing that summary. But just in closing, would you mind just highlighting what a high-quality opiate management program looks like that we've put into place here as part of one of our quality initiatives at American Physician Partners?
Absolutely. So, again, you mentioned this earlier. We want to be cutting edge. We want to be leading the fight against this opiate crisis. And the first thing we do, every physician that works with us at American Physician Partners has to attest to their enrollment in their state's prescription drug monitoring program. That's incredibly important. They need to look and they need to know if these patients have active opiate prescriptions before they prescribe anything else. That's the number one thing. Also is providing adequate education. We have two CME activities, wonderful programs. One is Scope of Pain, the other is EM Pain Line. Both are very robust. Not only are they robust in their educational quality, but they also provide maintenance of certification for both emergency medicine and internal medicine. The third piece of this is to make sure that our site medical directors are working right alongside with the nursing leadership to create policy around how prescriptions are written, how many prescriptions are written, and what happens if one of our providers falls out of line, which they're not necessarily doing that on purpose, but we have to have a re-education process in place for each provider should that happen. We also need to make sure that our EMRs are equipped to handle the documentation that surrounds the fact that we've looked at the state's prescription drug monitoring program. We've evaluated it to make sure that longer than 3 days is appropriate. And the final piece is to make sure everyone understands that this is a change, that we are trying to do the best thing, that patients aren't always going to be happy, and we need to make sure that we are communicating effectively with each physician. We have taken a strong stand in support of responsible opioid prescribing, and I think we are cutting edge right now.
An interesting statistic came up that really supports that, what you shared. And as we were doing one of our ED operations meetings this week at one of our facilities, it was noted the marked reduction since the time we had started 8 months ago in that hospital contract, the same period of time in 2016 to the same 8-month period of time in 2017, 55% fewer narcotic prescriptions leaving the emergency department under a watchful management group today, which creates a safer care experience for those patients and certainly a safer community that we've been able to create there for care. So highlighting a testament to what responsible pain prescribing can do. Eric, it's been a privilege to have this conversation with you today. Thank you, my friend, for your physician leadership, for sharing your knowledge today with our team, and for the leadership that you provide in leading the way for us delivering a high-quality, patient-centered care experience.